Good afternoon, everyone. Welcome to PYA's Unscripted series. Today's topic is physician retention. PYA is happy to present today's webinar on this important topic. Today's webinar is participation-based and uses a polling platform called Slido. To participate in the polls, you can either scan the QR code on the screen with your phone or go to slido.com and enter the event code on this slide into the event code box at slido.com. You may submit questions during the webinar by typing a message into the questions section of the Slido poll. We will attempt to answer as many questions as possible during the webinar. And with that, I would like to introduce our presenters, Angie Caldwell and Aaron Newcomer.
Terrific. Good afternoon, everyone. I'm Angie Caldwell. I'm a principal with PYA, and we are so happy to have you with us. With me is my colleague, Aaron Newcomer. Aaron, if you'd like to introduce yourself.
Hi, everyone. I'm Aaron Newcomer. I'm a manager here at PYA, and Angie and I work closely on a lot of these topics, so we are excited to talk about physician retention today.
We really are. And so a little bit of background on this topic. So just as a reminder, Unscripted is a little bit different than PYA's other webinar series in that with the unscripted format, we're able to share perspectives with you as the attendees, but as attendees, you're also able to share your perspectives with us. And in doing so, we're able to really learn from each other and gain a broader perspective. And so we're excited to bring this topic. Our last unscripted, actually the one before last, we asked a lot of questions about what, where your minds are with respect to physician recruiting and value-based compensation and compensation design. And one of the topics that kept coming up, kept rising, was physician retention. And that's why we wanted to have a particular focused discussion on this topic with you today. So as we've said, the unscripted format does use a polling platform. So on the screen in front of you, you're going to see a QR reader, so you can use your smartphone to pull up the polls. Or if that makes you, you don't want to use your phone and you want to join via your browser, you can absolutely do that as well. And you just go to slido.com and enter the number that is on the screen in front of you. And please don't worry, that number will stay, that number will reappear on the slides, and we'll actually put it in the chat for you as well, so that you can access that at any time. But hopefully you've been able to access the poll, and we look forward to getting started. So then with that, the link is, the website is still on the slide, and also the QR code, the QR reader. But let's get started. Let's get in and let's get warmed up. So tell us your favorite season: summer, fall, winter, or spring. This is just fun for us to allow everybody to think about the platform and to get used to using it before we get into some deeper content. So while you're answering and we're watching folks come in on this, I'm in Florida. I'm located in Tampa, and we just started spring. I was actually talking about that as we were beginning, right before we began the webinar today. We are having some pollen down here, which is typical for this time of year in Florida. We really are in full spring season by mid-February, and it is definitely my favorite season.
And I'm not surprised at all by the 0% winter after what we've had the past few weeks. The other thing, just to remind people as you get using Slido, that all the responses are anonymous. So while it might not matter on this question, on subsequent questions, your responses are anonymous. So please feel free to respond honestly. And then the chat function in GoToWebinar as well. If you want to ask us questions as we go along, we'd love to answer them.
Thank you, Aaron, for that reminder. And also, we know that we have participants from many different roles and many different organizations. So we also understand that we have some of our other firm consultant colleagues in the audience. And so we want you to be able to participate as well. Just answer honestly and represent what you see in the industry in your role as a consultant. But again, we want everybody to have fun and be able to share their perspectives with us today. So with that, let's jump in to physician retention. So what percentage of your physicians do you think are currently considering leaving? And I realize that this might be an unfair question because it's asking you to get into the minds of your physicians. But many of you working closely with physicians as you do, I'm sure you have a very good sense, spidey sense as to many of your physicians and conversations that they've had with you and what they're thinking about from a employment or affiliation perspective. So we've got about 10 to 20%. Of the highest number here is about 43% of you believe that about 20% of your physicians are considering leaving your organization.
And we might really be measuring here how many of you are optimistic versus pessimistic, but I think it's still important to highlight the importance of what we're talking about today based on these responses.
Exactly. So 45% of you think probably somewhere between 10 to 20% of your physicians are considering leaving. That's probably in line with turnover, known or perceived turnover ratios as well. So let's move on to the next one. In what areas are you seeing the most physician turnover? 1 being the most turnover and 5 being the least turnover. And so 1 is primary care specialties, 2 is surgical specialties, 3 hospital-based specialties, or 4 physicians with administrative duties. So here we are asking which type of physician is leaving or where you're seeing the most turnover. So now the results are starting to come in. It's a race. It's a race between hospital-based and primary care. Things are moving around a little too much for me still. Looks like we're going to settle out with hospital-based specialties as the winner, even though the polls are continuing to move a little bit. And that's in line with what I'm seeing as well. Aaron, how about you?
Yeah, hospital-based specialties recently, certainly. Primary care is second, and I almost expected that to be first, just given some of the alternatives for primary care providers. So you've got all these minute clinics, urgent cares popping up, private equity getting involved. So I'm not surprised that that's up there on the list as well.
Right, and with hospital-based specialties, it's there is a lot of coverage type responsibility that might make the hours a little different and a little bit hard to balance from a work-life perspective. All right, very good. Let's move on to our next poll. What is the biggest factor causing physician burnout? And so this is a word cloud poll, so you are able to answer just in a word what you believe the biggest factor is. So while you're thinking about that and providing your responses to us, interestingly, Medscape, of course, has a report, and the report is the Physician Burnout and Depression Report, which I think it's a bit heartbreaking that we have a report that provides information on physician burnout and depression. But they just had their results published. And from a specialty perspective, Medscape has shared with us that emergency medicine is the specialty that is experiencing the most burnout and depression at 63% of emergency medicine physicians, followed by OBGYN, oncology, pediatrics, family medicine, and radiology at 51% of those physicians feeling burned out and perhaps depressed, followed by 50% of pulmonologists, anesthesiologists, gastroenterologists, and internal medicine physicians. The lowest percentage was 37%. So 37% of the plastic surgeons that responded to Medscape's survey indicated that they were burned out and or perhaps depressed, which that makes sense to me. And again, looking at the highest being emergency medicine and the lowest being plastic surgery, just based upon our understanding of their work patterns, that it tracks. It tracks.
And the responses here are not all too surprising either. Call coverage being the biggest one. I think we've seen a lot of specialties and physicians asking for at least compensation for call coverage where they previously haven't had it this past year. And then thinking about the response to the last question with hospital-based specialties, there's some work-life balance and staffing responses here. And when you think about those specialties, figuring out their schedule is a big factor for physicians. So should they be 3 on, 3 off, 7 on, 7 off? How many hours really constitutes an FTE? I think that's a big conversation for hospital-based specialties.
Absolutely. Yeah, and this is interesting too. So the bigger the word in the word cloud means the more of you answered in the same way. And so perhaps, you know, we really appreciate the feedback because perhaps the next unscripted should be on call coverage, perhaps because it seems that that is a huge factor impacting our physicians out there. And again, just as a reminder, you know, you're sharing information with us, we're sharing information with you. And also, please feel free to send questions in the chat and GoToWebinar. We'll monitor that as well. And we'll try to answer your questions throughout as time permits, because this is unscripted. So we want to be able to share as much information as possible with you. So let's go on to our next poll. Do you feel that your physicians currently have the adequate support staff to enable them to practice at the top of their license? Yes or no? So I know that this is when working with physicians, as Erin and I do, this is a question that has come up quite a bit with us, you know, in the projects that we're working on, and just impacting the physicians, and that if they don't have that adequate support staff, then they're doing things and it's taking time from them and caring for the patient and really having that direct patient contact. And so it's an additional burden and perhaps an element that's really driving burnout.
And I feel like maybe if we ask physicians this same question, you might see the responses flip to your point, where they don't feel like they have enough support staff, because a lot of their thoughts on burnout and what causes it can just be not the direct patient care aspects, but the things surrounding them, like support staff that affect their workflow. So it's an interesting perspective here.
Absolutely. So let's go on to the next poll. And this is my favorite poll type, with the different types of emojis at the bottom. So the crying emoji all the way up to the love emoji. So we're asking you to share with us how your physicians feel about their EMR/EHR.
If we see a heart eyes response, we will need you to put in the chat what EMR you are using.
Absolutely.
And I know we saw a sterner response on the word cloud, so certainly not surprised by some of these.
Right. It's pretty evenly split between the crying, you know, oh my gosh, really don't like it at all the way up to the kind of like it. So much of a physician's time is spent in the system, right? I mean, from a notes perspective, from a documentation perspective, and you know, it's something that they really do have to learn to love and really make it work for them in the best way possible. The systems have become so powerful as well that it's difficult sometimes to take all of that power and all of the things that the system can do, but then structure it in a way that works best for you and your physicians. And so there's a lot of tailoring then that has to happen for that system. So, I'm actually pleasantly surprised that about 37% of our folks today actually, they feel like the physicians do like the EMR.
Well, and the important thing to remember too is that the only thing more painful than an EMR that you don't like is trying to switch EMR systems. So if you are considering that, there's a lot of forethought and planning and communication that has to go into that process.
Absolutely. So Aaron, let's go ahead and talk to us a little bit more about burnout.
Yes, we wanted to share some statistics and some thoughts that kind of summarize the last few questions that you all were answering. So up here in the top left, you'll see there was a survey done by the AMA between 2021 and 22 that said that 40% of physicians were thinking of leaving their organizations in 2 years. So we saw about 10 to 20% in the question that you all answered. So certainly there's a percentage that maybe are thinking about it that you're not aware of that's out there, but the actual turnover rates are understandably lower than that. So if you look at some of the data on turnover rates, it ranges from about 5 to 20%, and you'll see on the right side here a 17% or so for physicians, about 25% for APPs. So the actual turnover rate is coming in less than that, which is a good thing. The other thing with that survey is it was kind of right at the height maybe of the effects of the pandemic a little bit. So we're right at that 2-year mark that it talks about there after the survey. So it's interesting to see what the turnover rates are now and in conjunction with who might be thinking about it.
And that physicians and APP rate of 16 or 17% and 25% respectively, the physician number is a little bit lower than the highest number that I've seen, which was probably about a third out there in certain organizations. And physicians do have a lot of different options from an employment perspective. The market, as Aaron, and as our attendees know, is very active. So we have a heavy demand and low supply, and it just creates for a very interesting recruiting environment for everyone listening and for us to observe as well.
And the other thing to highlight here is some of the reasons for burnout, which we touched on a little bit. You'll see on the right side the turnover rates for front office and back office support staff were somewhere between 30 and 40%. So even higher rates there, and that support staff coming and going, having to train those, trying to keep your good support staff, that's going to affect physician effort and physician burnout as well. And then the bottom left part here, you'll see some items highlighted from the Agency for Healthcare Research and Quality, time pressure, chaotic environments, work pace, culture. A lot of that is surrounding kind of the time that physicians are spending with patients, how much time they have to spend with them, feeling like they have to see another patient. And so a lot of that can be summed up there, affecting physician burnout. The other items that, of course, we'll touch on are compensation. That's a big one that goes hand in hand with burnout. And then relocation, of course. So physicians leaving, some of that is going to be due to relocation. And that's something that we might not have as much control over. So we're going to walk through a few more questions related to engagement and retention. I know the last few slides might have been a little bit of a downer talking about burnout and all of that. So we're going to try to get into some of the solutions to that. This first question here is kind of a demographic question. So how many physicians does your organization employ? We're just trying to get a sense of the audience here as we talk through perspectives and answer questions. Certainly retention and recruitment is going to be a little bit different for organizations that have 10 physicians compared to those that have 500.
And of course, we've seen over the past couple of years an increase in the number of employed physicians by a hospital or health system. But that's not everywhere. There are still some markets across the country where the medical staff and the community is still very much independent and and private and not employed by the hospital. So while we do see that number continuing to increase, that employment number continuing to increase, there are some markets that change hasn't taken place.
I think it was last year, maybe the year prior, that it finally got close to the 50-50 split of employed physicians versus independent. Prior to that being more independent. So there is that shift, definitely.
Right. And then with this poll too, you know, for our practice, for our physician practice folks that are attending today, you know, of course, probably there are some physician practices that are quite large and do employ a number of physicians. But of course, it's a different but same problem when it comes to recruiting.
Absolutely. So we'll go ahead and move on to the next question. This is another open-ended question, not a word cloud, so you can put more than one word, but we really want your honest and creative answers here. So what physician retention strategies work best in your organization? This can be compensation components that you feel really attract and keep your physicians. It can be special benefits that your organization provides that they really like. It can even be a food truck outside of your building, because I think that would probably work on me.
Ice cream. The promise of no new EMR might be another.
The first couple flexible schedules in here. We've already talked about that a little bit, so that's not surprising. I think that's a big one, especially recently with the shift in it being more a physician market and physicians moving around. And compensation, we'll share a little bit more on compensation later, and maybe some incentives that you can work into compensation plans that'll help with retention and recruitment as well. So we do want to share some specific statistics on that.
The great thing about this format too is it's you know, not only allowing us to gather information, but everyone in attendance is seeing what others are doing as well and what's working best for them. So one of the takeaways for everyone on this slide is that most of the respondents here are saying that flexible schedule is one of the things that works the best. And thankfully, Slido has taken the count for us and put that at the top there with the answers, but flexible schedule, you know, competitive compensation and benefits. So all of those things, of course, very, very important. And I think I've seen leadership a couple of times now as well.
Yeah, and we do have a question on that later too. They'll probably highlight some more insight, but a lot of these do relate to the culture item that was highlighted in that ARC study. So physicians being involved in their organization, physician leaders here, do they have a leadership role? Do they have a voice? I think that's a big item that was just highlighted here by a lot of you. So that's something to think about. Mm-hmm. We'll go on to the next question here. Does your organization pay retention bonuses to physicians? So this is just a yes or no question, if your organization uses that or not. Honestly, Angie, I haven't seen it. We do see it, but it's not been a hugely common component from what I've seen. Certainly, if there are physicians that are getting offers from elsewhere and there's competition in the area, that's when we start to see it a lot more. But I do feel like sometimes when a retention bonus comes up, physicians might want to see those dollars elsewhere in their base or in their bonus or somewhere else. So I think that's something that prohibits this from being a little bit more common.
Right, and I know, you know, there are specific compliance requirements around paying retention bonuses, but overall, when they are compliant and organizations are able to use them, they are effective. You're able to do it in a way that's addressing an immediate concern for your organization and perhaps stabilizing a certain specialty and a certain physician in a market. So they are an important tool and one that we do see. We don't see them every day, like you said, Aaron, but we do see them fairly often.
And it's hard to figure out what your organizational philosophy or rules are around retention bonuses because they are so specific and case-by-case basis. It's almost something you have to approach as there is kind of a supply and demand issue in a certain specialty in your organization or with a physician. You almost have to approach it as a singular case. And that's where it's important to think about the criteria and requirements you mentioned from a regulatory perspective as you think through that. But we've got about 2/3 that don't use it, about 1/3 that do use it. We'll go ahead and move on here to the next question. So are your physicians compensated based on individual productivity? So the way this question is framed, probably a lot of you are initially thinking work RVU bonus, which is the intention of it. There are a couple other individual productivity measures that we can think about, but as we think through what was in that ARC study that we talked about, as well as what we've heard from other physicians, the time constraints that they have with patients. Sometimes spending more time with a patient can generate more work RVUs, but sometimes not. So the pressure that they feel to see another patient and that next patient can be a factor in burnout. And I think work RVU compensation has been very big. A few years ago, when there was a big push for more value-based compensation, I think it decreased a little bit, but as people have tried to figure out how to measure the value-based metrics, whether it's cost-based or quality-based, and trying to figure out how to get real-time data in that, I think work RVUs have stuck around and we still see them in majority of models. So I think it's going to take a little bit more before that goes away anymore, but it definitely is a factor in physicians feeling pressure on their productivity.
It's an interesting balance to have to strike, right? So from an administrative perspective, we all love a good work RVU. It's published, it's easy to measure, it's generally easy to track. It's a well-established practice for paying physicians, but yet it's interesting that the compensation model and design itself could be a cause for some burnout, especially when the physician is wanting to spend more time with the patient and, like you said, kind of work more diligently in the care plans and not be tied to or thinking about where that next work RVU is coming from. So like you said, Erin, I totally agree. Probably as value-based compensation and value-based reimbursement continues to increase with, it depending upon your market is whether it's hot or not. But as that continues to increase, I think this is something that is going to continue to get looks and more consideration as, how is the compensation design contributing perhaps to physician burnout and concern?
Yeah, the compensation design is an important aspect because, again, it's not a one size fits all. It can be specialty specific, and even within that, it can be physician specific. We have examples where we're helping with comp design and they're considering a work RVU component, and half the physicians in the specialty don't like it, and half the physicians in the specialty do like it, just depending on their personality, their practice pattern. So it does take a lot of considerations when thinking about if a work RVU component makes sense or not. We'll go ahead and continue to the next question here. So what percentage of your physicians have time carved out for an administrative or leadership role? So this hits on a couple of the responses we saw in that open text poll about physicians having admin and leadership roles and having a voice. And the thinking behind this question related to burnout is that physicians are going to have administrative duties no matter what, whether that's charting in between patients, paperwork, scheduling. But there gets to be a certain point where if they're providing certain administrative services and they don't have that time carved out, that's contributing to that time pressure they're feeling along with their clinical duties. So certainly it's not going to make sense for every physician to have an administrative component of their agreement. But in thinking about your physicians that provide more of those kinds of services, your medical directors, your important physicians in your service lines, and just your organizational cultural leaders, if you will, it may make sense to have some with carved out time. So we see the biggest answer is 6 to 10% here. So not the lowest bucket, but the second one there.
You know, and this is another area where balance is important, because not every physician will want to serve in an administrative or a leadership role. But the ones that do have the propensity and the desire to serve in these roles, it's almost a need for them. And so when we're thinking about burnout and satisfaction, those physicians have a need to have a seat at the table and be heard. And so it is an important element of, you know, thinking about, it's a retention strategy in some instances with certain physicians. Like you said, you can't, it would be incorrect to pay every physician for a leadership role within the organization, but it is something to consider for, again, from an individual perspective, just like the productivity. Some physicians love it, some don't. Some are going to love those leadership roles and some not.
And it becomes even more important of a consideration if your organization is academic at all, if physicians have teaching responsibilities or research responsibilities, making sure that they have adequate time carved out for each of those so that they are fulfilling what their responsibilities are in that role. So we'll go ahead and move on from this question. So what data does your organization regularly provide to physicians? So you can select more than one here. And as we think about this, I think we see the productivity and the compensation data. Those are maybe some of the more straightforward measures. And we see productivity here kind of taking the front immediately. The clinical quality and hospital operating, as we think about kind of the value-based push, you can tell that we did a previous unscripted webinar on value-based compensation because we're talking about it a lot. But those clinical quality metrics and those hospital operating metrics are maybe harder to measure, but are becoming more and more important as organizations get the possibility to earn more in reimbursement from value-based metrics. And as physicians have value-based components in their contracts more, I do think that's something that they're going to want to see going forward.
And one of the reasons that we're bringing this up is that when we are working with organizations and talking about, you know, recruitment and retention issues of physicians within their organizations, you know, we do hear that, you know, the physicians are saying, well, gosh, it's a black box. I just really don't know what the compensation is until I receive it. And then there might be some additional information with the productivity bonus payout that allows me to reconcile. But of course, the trend, and as a recruitment tool for those that are looking at this from, you know, purely through the recruitment and not the retention lens, but this is a selling point for your organization. The more transparent your organization is with sharing this information to physicians, this can become another bullet point in your list of great things about your organization, physician knowing that you're sharing this information with them. And of course, the trend that we're seeing across the industry, there are platforms like Statera out there that provide great information and transparency to physicians and on a regular basis, which we know is, and what we're hearing is truly appreciated.
Absolutely. When we do compensation design projects and when we talk to physicians and do interviews, I feel like the number one thing that we hear from all of them is transparency. They want to know what they're earning, why the amounts are what they are, and they want to know real time. They want to be able to check in and know how much they've done and what their paycheck is going to look like. So there are certainly ways to make that data more accessible and consumable. Now moving on, we wanted to share some information here again, just highlighting some of the engagement and retention questions we just asked and summarizing some of our thoughts on how to help those issues. So using technology to your advantage. This can be a couple of different things. One of them is what we just talked about in terms of dashboards available to physicians. So there are compensation dashboards that they can have access to. There's maybe clinical data that they could have access to that as you're measuring value-based things or clinical measures, that they would like to see their progress on so that they can make real-time adjustments and corrections and improvements. The other side of this is, of course, the EMR. If your physicians don't interact with their EMR well, and if it's burning them out, trying to figure out how to use that more efficiently can take some of that burden off of them. 2 and 3 here, practicing at the top of their license and encouraging teamwork, go a little bit hand in hand. We talked about support staff a little bit, and there's some benchmark data that you can look at kind of as a minimum or a pressure test. So at the median for a multi-specialty practice, it's about half an APP and about 2 RNs or MAs that support 1 FTE physician. And certainly that can change depending on the specialty, the physician's productivity, patient acuity, and all of that. But as you think about what support staff you have in their roles, using them for things like care coordination, for triaging, for APPs, helping with call coverage and things, that can all take some of the burden off of the physicians to let them practice at the top of their license. And compensation.
Go ahead, Erin. And then, okay, go ahead and I'll circle back.
Okay, we said we would talk about compensation, and we will throughout. So thinking about the model, thinking about work RVU productivity bonuses, and thinking about retention bonuses, we did want to mention again the considerations for the start criteria. So if you are paying a retention bonus, thinking about if there's an offer to the physician, and thinking about what the amount of the retention bonus can be. There are guidelines around that that are important to consider.
So what I was going to mention too, and I'm sorry to have jumped in on you, but thinking about allowing the physicians to practice to the top of their license, many times 1 and 2 go hand in hand. So the technology has to be in place to allow the physician to do that. Talking about that support staff, one area where we see organizations sometimes struggle is having that support staff in place when the physician is onboarded and hired. And so when you're starting off, you've successfully recruited the physician, they come in, but yet the support staff isn't ready and waiting for that physician. And so they immediately then get started perhaps on that wrong foot because they don't have that support staff ready. And so then the organization is playing catch up. So ensuring that the support staff is there and that technology is there when the physician starts is sometimes one of the best things to do from a recruitment and a retention perspective, and just letting them know that it's all going to be ready for them when they arrive is likely a relief.
And it's not just the APPs, the RNs, the MAs that we mentioned. It's also scribes, it's schedulers, it's prior authorization people that can all contribute to the physician being able to spend more time with the patients and not having to worry about other issues. So we'll go on into our kind of third section of questions here. To talk about recruitment a little bit. And this first one here, what recruitment incentives does your organization offer to physicians? And again, this is a select all that apply. When I think about this, Angie, the signing bonus, I honestly don't see a lot of offers that don't have a signing bonus in them, at least recently, certainly for physicians that are not a part of the organization already, but we see signing bonuses generally in most offers. Relocation assistance for physicians that are moving areas, again, not your physician that wants to renegotiate his contract and happens to be moving down the street, but for reimbursable expenses, we do see that. Education loan reimbursement, you've been doing this longer than I have, Angie, but I feel like a few years ago, I didn't see this at all, and I've seen it pop up a little bit recently, specifically to help with recruitment of residents. So people that are coming out of school, they want an offer and they want to know that they're going to come into that job not saddled with debt. So I have seen that a little more recently be a recruitment tool there.
Absolutely, I do as well. And we really encourage those that answered I guess maybe somebody changed their answer. Other recruitment incentives, if you want to share those in the chat, would certainly appreciate it, and we'll share information as it comes there. But signing bonuses, as you said, Erin, are prevalent out there from a recruiting perspective, and they are getting larger. And I'm sure if we could see the faces and and body language of our attendees today, they're nodding with that statement as it relates to signing bonuses. Of course, best practice with that is to have some kind of a clawback on those signing bonuses, so that you are holding the new recruit to a time period for service after joining your organization. After all, you've worked very hard to recruit the physician and want it to be successful, and so requiring some time with that signing bonus is best.
And we, of course, would be remiss if we did not mention that when thinking about all of these incentives, they are considered a part of compensation. So when you think about total compensation and when you think about fair market value, these are all things that are taken into consideration. Well, moving on here. Does your organization complete or use a provider needs assessment to determine your recruitment needs? So a yes, no, sometimes, or a don't know. And a provider needs assessment, or a PNA, I think, is a good tool for staying ahead of recruitment. So there's nothing worse than a feeling of a physician leaving and not knowing how you're going to fill what that person was doing. And so a PNA can help you figure out in your market by specialty where the needs are now and where the needs are going to be in a few years. And so I think it's a good recruitment tool. And we'll see that we see now about 2/3 are using it, which I think is a good sign.
Absolutely. And glad to see folks are using that as a tool. While some more are answering this question, I do want to answer a question that came through on the chat. We are unscripted, so we're going to answer the questions that come through to the extent that we can. Any thoughts on how baby boomers, Gen X, millennials, and now Gen Z, how their work styles are colliding and how that impacts retention? So Erin and I are smiling because, of course, we're in different generations. In fact, Erin did call me old just a little bit ago about how I'd been doing this longer. But when what you're seeing and what you're hearing about the generational impacts is the same for physicians as it is really for the rest of us. And what's really interesting is that, you're going to have the older, the boomer, Gen X generation. Some of them are going to be very willing to pass things along. They want to leave the legacy in their practice. They want to leave that legacy. So they are very willing to bring in, the new physician under their wing and really help them out. And that in and of itself, within a compensation design and a compensation model, should be rewarded. You're really working on that mentorship from that older physician to that younger physician. Where we see that generation really start to cause problems, and I'm going to use radiology as an example. So in radiology, a lot of the younger generation, of course, they are saddled with student loans. They're, starting out on in their work life. And so some of the primary focus is compensation. And so perhaps they're more willing to take a job that has less interaction, less leadership, less relationship building, just to get through and to get the work done. And so sometimes that creates that push-pull between Gen X and baby boomer generation and the younger generation. We hear that a lot. Also in specialties where there's a group model. And so what I mean by that, you have the older physicians who are ready to pull, ready to start to wind down, and the new physician coming in might not have the productivity that the older physicians do, just because they aren't as established in the community. So then looking at them as a group and how that group operates, that too creates that push-pull, because the older physicians aren't willing to let go of compensation in a productivity model just yet, but the newer physician is trying to make more compensation in that productivity model, and they're just not as well known yet. So it is a real struggle, and some of the dynamics are consistent with other work as well. Erin, would love your comments.
Yeah, and it's a great question. When we talk about recruiting and planning for recruiting, we're really talking about succession planning. And as we know, there are a lot of physicians nearing retirement age. And so a lot of the recruitment planning and needs are figuring out how to transition those physicians to some of the newer physicians. And as we see some of these less frequently used compensation components start to come in, those new physicians are wanting the signing bonus. They're wanting the education loan assistance. They're maybe wanting a guarantee for a couple years of compensation when they first start, so that if the productivity isn't there, that they can work up to that. So I think it's forcing organizations to become a little bit more creative in terms of how they structure offers, in terms of how they structure compensation for some of the newer physicians, because there's more options out there now, and a lot of these models are becoming more dynamic. There's more information that people want access to. So there are different perspectives that certainly have to be taken into account.
Absolutely. Absolutely. Our next question is, what specialty is the most difficult to recruit? So this is you just type in your responses and we'll be able to see those. Of course, there's great survey data out there on this information, and we always watch that very closely. The answers that are coming through on the screen so far, there's no surprise to me yet, and there is one that has not popped up yet. That I'll comment on in just a moment as the poll responses continue to come in. But Erin, do you have an immediate reaction?
Yeah, I wonder if we're thinking of the same one that we're waiting for. So I'm not going to say it yet, but there's your radiology on the screen that you mentioned earlier. I was expecting to see some hospital-based specialties here and some of the procedural specialties, I think, like GI, like urology. I think recently we've heard a lot that there's trouble recruiting those in certain settings.
Yeah, the OBGYN has popped up. There it is. There's the one that I was looking
for as well.
So anesthesiology popped up. We hear a lot in anesthesiology and even with CRNAs. So as the anesthesiology physician supply continues to shrink, of course, the demand for both physicians and CRNAs continues to just blossom, explode. And so that continues to be a specialty that we see a lot of difficulty recruiting. OBGYN is very interesting as well. There's a lot of demand on an OBGYN physician from a delivery perspective and a malpractice perspective as well, which I can see has really, likely impacted the supply for OBGYN, and especially in rural markets, where you're maybe the only OBGYN in a number or hundreds of miles. It becomes a real difficulty. Some practices see great success in OBGYN recruiting when they can really make the practice almost a boutique practice, focusing on women's health. Again, not limiting payers to that practice, but really focusing on and making it at boutique. So really providing the range of services from obstetrics to gynecology, and then getting into some of the things that many women know and love, including, all the fun Botox, fillers, other things, and really making it a women's health practice and not just an OBGYN practice. We've seen a lot of success in those types of practices. Erin, this is fascinating. Any other comments here?
Yeah, I like the answers here rolling in, and I'm surprised I haven't really seen a lot of primary care answers. But to comment on neurology, that's the highest. I think recently I've heard some crazy wait times from physicians about neurology appointments where it's, multiple months until they can see a patient. So that one doesn't totally surprise me.
Yes, epileptologist as well, you know, just because again, it's such a subspecialty within neurology, really seeing some difficulty recruiting there too.
And there's your ED physician was there too, which was on that burnout list.
Yeah, you're absolutely right. At 63% of emergency medicine physicians feel burnout or depressed. So our next poll, how much is your organization currently spending on locum tenens coverage? So while you're thinking about and responding to our poll here, the purpose for this question is really thinking about locum tenens dollar spend as a way to determine where your recruitment needs are, where your retention needs are, and where the holes are. I'm sure we're not telling you anything that you don't know, but the higher the spend within the organization in a certain specialty as it relates to locum tenens coverage is an indication of a need for that physician. So many of you are coming in at not sure, you don't spend any, which would be wonderful, not to have to spend any. But then the second is in that largest bucket, coming from our largest of organizations that are attending the webinar today.
And the large numbers don't surprise me, unfortunately. I have seen recently something creative. There was a compensation bonus that was tied to the reduction of locums use in that specialty. And so it was physicians picking up extra shifts or physicians helping with recruitment. And I thought that was a creative way to kind of address those issues.
Yeah, well, that's great. All right, moving on. What percentage of physicians are recruited from outside of your state? So this is, again, recognizing the supply and demand issues and thinking about the migration of population after COVID. So if you think about, we've all seen the maps that, you know, many folks are moving from the Northeast to the South. And that, of course, has created an additional demand in the South and in other states. Colorado, not in the South, but a state with a large increase in population. And what we're seeing there as a result of that, of course, is higher compensation for those physicians. Supply and demand, simple economics, it will eventually level out and the increases will eventually stop. But it is real, and this is a challenge when recruiting then, especially if you're in one of those states, Tennessee being one of them, Georgia, Florida, also having large increases in population. You are forced to look outside of your immediate region to recruit into the state, and perhaps at higher compensation when you do.
Well, and it changes your thinking about physician offers and recruitment. So conventionally, if you think about there's a competing health system in your state or city, and they're offering X dollars for a certain physician, you feel like you have to match that to recruit a physician. You're now also having to worry about across the country, a health system is offering Y dollars for that same physician, and how far off are you on that? Because those physicians are looking, you know, not just in one area, and they're not just being recruited from one area where they are in school or where they might be. So I think it kind of broadens the thinking in terms of recruitment.
We did get another question in the chat before we wrap up today. The question is, curious as to if there has been an uptick in income guaranteed arrangements with private practice given issues with recruitment and retention. So I'm going to say yes, that there has been an uptick in income guarantee arrangements with private practice. Again, recognizing that, and if we go back to the generational question that we had a few moments ago. So capturing the entrepreneurial spirit of some of the younger generations that are coming out, they may not want to be employed by a hospital or health system, and they do want to be become a partner one day in a private practice. So sometimes in certain markets, it's very, very attractive to a young physician or a physician to be recruited by the practice. And so then that provides them that opportunity between the practice and the hospital to create that income guarantee to help that practice bring that physician into the market and secure the arrangement while that physician is building up their practice locally.
Well, and with the shift from physicians going from independent to employment, or for going from private practice to hospitals, those physicians that still are owners in a practice, when they're doing succession planning and trying to recruit physicians to pass this along to, they're maybe having to lean on hospitals or other organizations to help with those income guarantees to attract those kind of physicians. So I think that's a good question.
Absolutely. So in wrap up, the slide on the screen in front of you is really a summary of the last few questions that we've asked. But just as a recap and a reminder, on the left-hand side, we have some key elements for recruitment planning that will help an organization understand, kind of really getting ahead of what needs to occur from a goal perspective and from addressing a need perspective in recruitment. The last one is one that we didn't talk about that I want to comment on, and that is just from a recruitment perspective, it's so important, as everyone knows, to create that pipeline for your physicians. So the recruitment season and the recruitment opportunity really begins much earlier than it ever has. So you're really, we've heard, and I've become aware recently of recruitment strategies that are even reaching out into high schools and really trying to capture that talent and those individuals who want to stay in the market once they graduate. And so folks are creating relationships even with juniors and seniors in high school to really make sure that they're supportive and they create that relationship in hopes that they are able to come back and secure them in their local market. So something, a new trend that we're seeing, it's just that maybe not a new trend that we're seeing, but the trend is that connection with that individual is starting earlier and earlier, even at the high school or possibly even younger age from a pipeline perspective. And then on the other side of the slide, as it relates to recruitment incentives, we've talked about all of these. I'm going to spend my time on other. And so one of the things that we're seeing that's being, again, talking about the pipeline and ensuring you're keeping that person in their local community. On the incentive side, we're seeing this in that fellowship repayment or that fellowship support that physicians are getting. Perhaps you prepay that signing bonus related to that physician, and of course there's clawback to that, so it's all good from a compliance perspective, but that's just helping that physician through that schooling time, through the end of their residency, and really shoring up their coming over to your organization and a successful recruitment. Aaron, any other comments before we wrap up?
Just in the other bucket, that we've seen some creative benefits and compensation as well. Things like dependent tuition reimbursement for physicians with kids that are going to school and things like that. So it is all part of the total package, but don't be afraid to get creative with it. Absolutely.
So with that, thank you, Aaron, for participating in Unscripted today. We never know what we're going to get. So it's a super fun format, and I really appreciate you collaborating with me today on this. Thank you to everyone attending. I'm going to turn things over to Caitlin for a proper sign-off.
Well, thank you so much, Angie and Aaron. We really appreciate it. Later today, everyone will receive an email with their contact information and a recording of the webinar. Also, all of the information on this and future episodes of PYA's Unscripted series is available on the Insights page of PYA's website, which is pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thank you so much for joining us, and we hope you have a great rest of your day.